Welcome to the second episode of OT Time, where we explore the world of occupational therapy through the eyes of OT students in Singapore. Whether you're an aspiring occupational therapist or just curious about the field, this podcast is for you as we dive into the world of mental health in occupational therapy. I am Karmen, a second-year occupational therapy student at the Singapore Institute of Technology. You might remember Cera from the previous episode on pediatrics.
Hi, I'm Cera, a fresh graduate from the SAOTSC program. Like what Karmen mentioned, please check out the other episodes of OT Time podcast. I promise it's pretty good.
Today we have a very special guest with us, and she's the Cluster Director of the Health and Social Sciences Cluster at SIT. Prior to SIT, she served as the Head of Occupational Therapy Department at the Institute of Mental Health for 11 years. Wow. So Professor Bhing Leet also teaches mental health in the Occupational Therapy Department at SIT, and I've been blessed to have been taught by her across 3 modules such as the application of psychopathology in occupational therapy.
And Prof Bhing Leet also serves at the World Health Organization Development Group for Schizophrenia. She also serves in committees in AWA, Elkin Singapore, and Minds. She is a recipient of the National Day Award Commendation Medal, National Healthcare Group Allied Health Senior Educator Award, the SIT Teaching Excellence Award, and the Coney Labelle Science to Practice Award. To many of us students, Prof Bhing Leet embodies what the calm and zen in mental health is, and we are really glad to have her with us today. So let's welcome Prof Bhing Leet!
Hi.
Thank you for joining us here today, Prof Bhing Leet. So we are very excited to ask you a lot of questions today, but maybe we can start with something very simple. Why do you choose OT, and what inspired you to become an OT?
Okay, so I think by now all of you all know what occupational therapy is.
I actually don't know.
Oh,
yeah, maybe you want to tell us.
Maybe for some of our viewers, we have studied, we know.
We know,
but
yeah.
For your
So occupational therapy is a profession where we help people with all kinds of conditions, from medical, developmental to mental health conditions, to regain their life roles, to assume occupational participation. So in layman's terms, it's called functional daily functioning. And also then to enable them to be able to perform the roles that they value. So in the areas of daily living, in leisure, as well as at work. So mental health is is actually a very interesting field within the profession of occupational therapy, because the origins of occupational therapy profession actually started in the area of mental health. So years ago, during the arts and craft movement in Europe, that's where the occupational therapy started using activities, and they realized that activities has a very therapeutic potential for healing for people with mental health problems. And then since then, the mental health, or rather the occupational therapy profession then started. Then over time, occupational therapy started treating clients with medical conditions, with also children with neurodevelopmental problems and so forth. So as to why I specialized in mental health, well, that was a long time ago. So I started working as an occupational therapist in the late 1990s. So at that time, I was working in hand therapy as well as mental health, and subsequently in neurosurgical wards and in mental health at the same time. So while I was holding a variety of cases, I realized that occupational therapists can actually play a very huge role in the care of mental health patients. And I was very privileged to work with a team of mental health professionals in the psychiatric facility. So I was very young and hungry to learn new skills. Therefore, I learned a lot from the psychiatrists and also other mental health professionals. And through that, I also went for further certification in certificate in stress management and a certificate in cognitive behavior therapy, and realized I could actually apply what I learned very readily in the clinical setting. So that actually sparked my motivation to further hone my skills in mental health. So I think in 2002, I then pursued a master in mental health at King's College London. So over there, I were exposed to a lot of different approaches. For example, the psychodynamic approach, cognitive analytic approach in the treatment of mental health patients, particularly in people with borderline personality disorders. So I think these are skill sets that were very, very valued by me at that time, and I found them very, very, very useful in my application with the mental health clients. And of course, subsequently, I then went to the Institute of Mental Health, where I then worked with people with a variety of conditions, but predominantly with schizophrenia. And again, I was working in a multidisciplinary team, and at that time, I then could understand that occupational therapists, together with other healthcare professionals, not only should just carry out intervention, but have a huge role to play in other aspects of mental health care, be it mental health prevention, advocating for mental health, and also working with the stakeholders and also public in raising the awareness of mental health. So that's where we actually did a variety of activities, such as giving public talks, training certain professionals. I think the psychiatrists were training general practitioners. As occupational therapists, we work a lot with clients in vocational rehabilitation and then subsequently supported employment. So that's where we did a lot of training with potential employers. And of course, we also work with families, we work with the public, we work with our community agencies, partners. So that actually makes the life of a mental health occupational therapist very interesting. You know that in order for them to recover, in terms of their, not just the symptoms resolution, but also in terms of their ability to be able to function in daily living in the community, as well as to be able to hold down a meaningful, valued occupation. We actually need to work with a variety of partners in order to make that happen.
Yeah. Prof, then I have a question, because you mentioned about public awareness about mental health, and it seems like only in the recent years that mental health has been an issue that is talked about a bit more. So I was curious to find out, at the start in the 90s, when you heard of occupational therapy, did you already know that OT actually works in mental health, and that you were already like, yeah, you know, I want to work with people with mental health conditions, and was it perhaps inspired by some personal experience or any other factors?
All right. So you were saying that when I was a student and choosing occupational therapy as a profession.
Yeah.
Before I took out the scholarship by the Singapore Government Public Service Commission to go to the United Kingdom to study occupational therapy, I actually did a job attachment at the Institute of Mental Health.
Oh.
So that's where I got some insights into the work of occupational therapists. And it was very interesting. So occupational therapists were working with outpatients, day patients, but also long stay patients to maximize their functioning. And at the same time, to still give them some quality of life, even though many long stay patients had to reside in the institution, but the occupational therapists were bringing them out for outings, and I realized that occupational therapists can help a wide range of patients, and they not just work on the symptom reduction, but work at how to get the person to live a good life. So I think that was very inspiring when I was at the job attachment. But at that time, I didn't think about specializing in mental health, because I think one advice to students is also to keep your options open. And in the occupational therapy course, you need to learn a variety of skills, and it's important. Yeah, it's important to learn a variety of skills for you to be competent enough to practice as a entry-level occupational therapist. So when I was pursuing an occupational therapy program in the UK, I just learned everything. And in fact, actually my clinical placement, my CPE, I did better in neuro than mental health. So never let CPE experience determine what you will work, where you will work in the future.
Wise words, wise
Wise
words.
words.
Yeah. I think just now you also mentioned that you started out working half-half, is it? Like not totally mental health, you were also working. Could you share with us any memorable experience whereby you suddenly felt that your time as a mental health OT actually contributed to your practice in another area?
Okay. I was working with hands patients and as well as mental health patients. So it could be hands patients on some days, mental health patients other days. Sometimes it's mental health in the morning and then hand patients afternoon. So it's a lot of switching of the gear. And I remember there was one case whereby the patient was in the psychiatric ward. He attempted suicide and he had a tendon injury. So he had a tendon repair and was on the spleen. So I was able to see him as a hand therapist as well as a mental health occupational therapist. So therefore, I thought that that kind of skills that I have in both the physical as well as in the mental health setting helped me. At the same time, when I was working in a hand therapy outpatient facility, there are also patients who were upset with their hand injury, and over time, I will also realize that some of the reason why they felt pain still, even though there were no physical signs or neurological signs of pain, is perhaps psychosomatic, is perhaps because of grief and other issues. So therefore, I think the skills in mental health also help.
I've got a question, Prof. So since mental health is also quite like a very different area, right? Are there some common misconceptions that people have about what a mental health OT does? Because I think typically when they hear, even Institute of Mental Health or you talk about mental health, everybody's like, oh, what? Are you depressed? Are you okay? And like there's a lot of like overcompensation or like, you safe or not, can or not, kind of like feeling. So maybe you can share with us what are some of the misconceptions that you have heard, like that people have about your job, or whether explaining to like family, friends, and give a bit of like a myth versus truth, to bring some right awareness about this.
Okay, there are a lot of myths about persons with mental health conditions. Sometimes there are also misconceptions about what occupational therapists do in a mental health setting. So for myths of mental health, actually years ago, I think it's 2005, we published a book called Myths of Mental Health, and actually it's called Grown Men Don't Cry and Other Myths of Mental Health. So I contributed to a chapter on employment, so myths about employment issues for persons with mental health problems. So some of the myths are that people may think that persons with mental health conditions are a liability. They will take long hospitalization leave and cannot contribute to the employing organization. And the fact is that persons with mental health conditions, if they are actually seeking treatment and they are actually working closely with their treating mental health professionals as well as the employers, then they could actually be able to manage their symptoms while still at work. And a lot of persons with mental health conditions, because of the fact that they know that they have a mental health conditions, so they feel that there's a need to work harder. Therefore, they're actually very committed to the organization, and many actually contribute very well to their employer. Then another myth is that persons with mental health conditions are aggressive and violent. And again, this is not true. We know from a lot of cases that persons who actually commit violent crimes or exhibit violent behavior, they actually do not have mental health conditions. And conversely, people with mental health conditions, even though with those with psychotic disorders, they actually are more fearful of people than they want to harm people. So this again is a myth. Another myth is that persons with mental health conditions cannot take stress. And we know that actually ability to take stress lies on a continuum. And if you are able to adopt a healthy lifestyle, be able to watch out for our mental health, actually persons with mental health conditions, they are able to manage work stress. And the fact is that a lot of them, when they have a mental health conditions and they acquire knowledge about their mental health problems, they are actually able to manage stress better because of the fact that they have increased self-awareness. And they have actually acquired the skills of managing their daily stressors when they work with mental health professionals like occupational therapists.
I like all that. I learned a lot about like how we can view people differently. I think something that we often hear also is like how occupational therapists are often mistaken as maybe like the physiotherapists.
Yeah.
Then in the, for example, when you're working in IMH, the people come to you and say, "Are you my counselor? Are you my psychologist? What are you doing today?" Like, do they do this sort of things like with you? Like, what are the different people that you work with in IMH, for example?
Okay, so to tie in your question together with Sarah's question, the myths about mental health occupational therapies is sometimes when you see OTs using activities like crafts, cooking, there may be a misperception that they are just occupying the patient's time or entertaining patients or are like volunteers running activities with patients. But the fact is that occupational therapists, we are experts in activity analysis.
We're very intentional.
Yes, correct. And we also have a lot of skills in looking at the person's body functions, the other domains like process skills, motor skills, social interaction skills, and we use activities to enable the person to acquire skills that is necessary to perform their valued roles. So this is not just occupying a person's time, but to actually use activities to enable a patient to recover. So as to the difference with other professionals, physiotherapists and occupational therapists actually work very closely together. And likewise, occupational therapists also work very closely with psychologists. So while psychologists may be conducting therapy sessions, a lot of times are talking therapy sessions, to work with patients in terms of their way of thinking, using different approaches. So they can use cognitive behavior therapy or psychodynamic therapy or other forms of therapy. Then the information that the occupational therapists obtain from the psychologists can then be used when the occupational therapists get the patient to apply what they have learned in the psychology sessions to the daily living activities that the patient is performing every day.
Interesting. So besides there's a psychologist, there's the psychiatrist, nurses, physiotherapists, occupational therapists, who else makes up the MDT team then?
Okay. The psychiatrist in the hospital will diagnose the patient and also prescribe medication. The psychiatric nurses will make sure that the patient is compliant to the medication and also educate the patient about the medication that they are having together with the pharmacist. Then we also have a psychologist, I mentioned, and they are clinical psychologists because they are trained to work clinically with patients. Medical social workers, they work with family members. And of course, occupational therapists, we having a holistic mindset. We look at the patient's motor functions, their cognitive performance, their emotional function, sometimes even looking at their spiritual aspects. So we are very holistic in our approach. That we use the information about all these functions within the patient and look at what are the activities that actually the person is interested in and or value in and enable the person to be able to perform these activities.
I see. So Prof, could you maybe briefly run through, for some of the viewers, like how does the process look like when someone gets like referred, like have a mental health case, whether is it admitted in the hospital or like what are the ways that people actually like get entered into this mental health care system, and how does the occupational therapist actually contribute to that process, and like a brief like recovery journey of how it looks like?
All right, that's a big question because mental health services have evolved such that there are so many ways to be referred to a mental health service. So for young adults, for youth, there's the chat service, and it was first mooted by the National Mental Health Policy many years ago, and this is a one-stop assessment center whereby youths can receive assessments and then receive mental health services if they require. And there are also nowadays polyclinics, and some of the polyclinics do have services whereby the patient, or rather a person, can actually receive assessments and then subsequently be able to receive services by the
Follow
mental
up, like
health professional.
counselling or like, yeah.
Yes, so it depends on the services required. And of course, there are other ways, such as a referral by a polyclinic to a tertiary institution, such as IMH, or it can be an outpatient service in the psychiatric unit in the general hospital. There are also inpatient services in some of the restructured hospitals, whereby occupational therapists also work in. So in some of these restructured hospitals, the occupational therapists work with both the inpatients as well as the outpatient services. And the services can range from general adult services, women's emotional health, addictions, etc. And also in the inpatient setting, where occupational therapists work with the patient in terms of looking at their functioning, looking at their occupational performance and participation, and then subsequently work out a plan with the patient and the family to follow up on the interventions that will benefit the patients. So upon discharge, the occupational therapist may follow up with the patient or refer the patients to an outpatient occupational therapy service. Besides outpatient services in hospitals, there are also step-down facilities. So community agencies, they do run rehab services such as the Singapore Anglican Community Services, Singapore Association for Mental Health, etc. So occupational therapists also work in these agencies, whereby they then carry out interventions and together with their colleagues in these community agencies, they then work out a plan and also, of course, implement a plan to help the patient to move towards recovery.
Seems like it's very diverse, like what occupational therapists can do in a mental health setting. I had the privilege of actually job shadowing at NUH inpatient mental health ward when I was considering whether to join the OT program. And then I saw them run a group for baking. Yeah, and then in my head I was thinking, why OTs doing baking? Like if I bake every day, I can do this lah. Yeah, I sure can. But of course now I learn there's AA and all the other social skills involved. How would you say that a typical day as a mental health OT would look like or describe your typical day?
Okay, so last time when I was working as a practicing occupational therapist, I might be seeing the patients in the morning, the inpatient wards, and some of the patients may be new patients, then that's where we need to interview them and get to know them. We may be carrying out assessments. There are a wide range of standardized assessments, so ranging from Allen Cognitive Level Screen to the Brief Assessment of Cognition Schizophrenia, to other ADL assessments, also instrumental activities of daily living assessments, like CALS and AMS. So all these standardized assessments allow us to get a glimpse in a very objective way of the different aspects of the patient's occupational performance. And I also carry out group activities, so I used to run a variety of groups.
Do you bake?
I used to, I did some baking groups also. And it can be quite, it can be very insightful to see how the patients are when they carry out activities. Because a lot of times when we interview patients, when psychiatrists, psychologists talk to patients, we may not have, we get actually their subjective account, which is great, but we will be able to see exactly how they communicate with others, how they work with others, how they self-regulate their emotions, what their mood is actually like when they come across a frustrating situation when we carry out an activity. So that's where we get very valuable information during group activities.
Do you have a favorite group activity to do?
Actually, I used to spend my weekends thinking about all the activities that I can conduct in the following week. So sometimes weekend I will go and check out what the popular things or popular activities that people were engaging in at that time. So I did baking, I did cooking, we did music, we did crafts, we did discussion groups, and also of course sometimes community outings to look at community mobility. I also carry out cognitive remediation because that's my area of specialization also. So it came about when I was working with the traumatic brain injury patients, when I was also working with the mental health patients, and that's where I realized that some of the skills that I picked up in cognitive rehab for TBI patients are also useful for persons with schizophrenia and other serious mental health conditions. And at that time, a psychiatrist also inspired me by actually showing that he actually did a research that showed that after a memory training, there were objective changes to the brain of patients with schizophrenia. So that actually caused me to embark on a research in this area. So I think I did my PhD on that back in 2007.
Wow.
I was 5.
I was older. I cannot tell you how old. Wow. Am I right to say you're also the first professor in OT in Singapore?
Yes, I'm the first full professor of occupational therapy in Singapore.
Wow. Okay.
There's a lot of scope for research in occupational therapies. I think we have a lot of very good occupational therapies in Singapore and also in other countries. In order for us to be able to showcase the effectiveness of occupational therapy intervention, we need to do rigorous research so that it can also bring about awareness among the other healthcare professionals. And research is something that requires a lot of commitment because you need to adhere to certain guidelines, you need to be objective, you need to be ethical about the whole process in order to deliver good research. However, the outcome is actually very satisfying because you finally know that what you do with the patient is useful or unnecessary. And it's also through research that the healthcare professions actually realize that maybe there are certain things that we do that are not so helpful, that we should not be doing in order to reduce the cost of healthcare and of course to do patient justice.
And that's what we call evidence-based practice, right? That we eventually move towards that. Sarah, you did your thesis. How do you feel about what Prof just said about doing research?
Actually, I think that's very important. So I also have the privilege of having gone through all my placements, and my last placement was a psychiatric ward placement at the Tan Tock Seng Hospital. So at the point of time, we were actually exploring expanding the mental health services there. So they actually do have a sleep clinic running in Tan Tock Seng, as well as some inpatient. We were starting some group activities. So when you talk about like evidence-based practice, many patients also sometimes come up to us, I mean family members also, whether is it in the realm of physical kind of conditions or in mental health. But I think especially more in mental health, they're like, why do you ask me to do this, or why do you ask my family member to do this, you know? It's only baking what I do at home versus you do, got difference meh? Then it's like, you same what, same. So I think research and therefore actually gathering measures is very important, and a lot of times it's not that it's not effective, but you really need to gather the evidence. So during my 7-week placement, we actually were able to help our CE. So we actually have some research, and we use one of the NUH group subjective reports on gathering data about how the patient feels before and after the activity with regards to stress levels and anxiety. So when we talk about inpatient stays, just expanding a bit about how it could look like in terms of referral into the mental health care system in the case of an acute restructured hospital. So there can be patients who come in who have schizophrenia in relapse, they have mood disorders, and actually sometimes we have a lot of comorbid diseases together. So some clients who are admitted for some stroke, or even like our geriatric elderly patients, and they detect that, oh, you know, they actually do have some mood, or they have background in like mental health adjustment disorder, they also get referred and we see them. So the standardized procedure is that OT is really about being client-centered, right, and tailoring to each person, especially when you come to mental health, that it's very personalized and highly subjective to the individual. So we do that kind of routine interviewing, but also really looking at what is this person interested in, and then we find the different measures. After that, we were brainstorming the group activity idea. So we were trying to group to say, oh, you know, like, are you interested in this? And the main brief areas, like what Prof mentioned, because we do skills training, and skills training also includes self-management in terms of like stress, or also like how you do your ADLs, but also like health management, like exercise, medication, which for a lot of patients with psychiatric conditions, they do have a lot of medications to manage. So a few of the groups that we did were, we had this a tissue paper, a flower making activity. So we were trying to help them to find an activity that they can do while they are staying in the hospital, or when they're at home with everyday items around them, how they can meaningfully occupy themselves and do something small that makes them happy and help to elevate mood. And the evidence-based practice come in because we actually bring the awareness of the patient to, okay, like, so now let's say on the scale of like 0 to 10, 0 being I'm very, very sad, you know, 10 I'm like, yeah, I'm happy, I'm ready to go, kind of thing. And then we kind of get them to be aware, and how we measure the success of the intervention is not by, hey, I think the person looked happy after, then okay,
just observation, right?
yeah, so it's not just observation, but through really checking in with the patient. So we asked them, well, so how do you feel after the activity? What was something about this that helping to facilitate that reflection? And if they say, you know, they may look like they're enjoying, or they may look like, wow, very stressed by the activity, but oftentimes, you know, you really don't know what's going on in their mind, and when you check in, they're like, oh, actually, I really enjoyed doing this, even though over then they were like, wow, I really need to like, wow, this one, draw this one very nice, you know, but they actually enjoy it. So it's helping to really collaborate a lot, with that client. And during this intervention process, because we believe a lot in being client-centered, and I think especially for mental health, it's about the person's goals and how do we help them to achieve that. And it's very subjective, right, based on each individual on how well they want to be, or how well they think they can manage, coupled along with our evidence-based practice. So after they kind of meet their goals, a lot of it is like what Prof mentioned, management of whether they can do their everyday activities, everyday functioning independently, what are the supports and the environments, the education we need to give to their employers, to their family members to support them, because the goal is not to have no symptoms, or the goal is not to have no relapse, but rather when they encounter these, you know, do they know what to do? Do they know how to have help? Do they know how to lower the stress or recognize their triggers before they actually have a full-blown like episode? Yeah, to reduce that readmission. So that's kind of like how that process goes on during the inpatient stay, and afterwards we will refer with collaboration with the medical social workers, the multidisciplinary team that was mentioned, to look at what is the next step for them. With the client being at the center.
Well, that's very insightful, Sarah. Thanks for sharing all of that. Don't you feel very proud?
Yes, I think that's such a good sharing, and I'm sure you've learned a lot in this placement.
Yes, say a lot.
I'm looking forward to my own like placement if I ever get in a psychiatric. I would, right? All of us have to go through one.
Yes, it's mandatory to have a psychosocial placement.
So, you mentioned about working with adults.
Yeah.
You've worked with different populations across your entire career, right? Are you able to share more about the differences through the populations we've worked with? I remember going up to you after class once and asking you about mental health among the elderly, okay, not elderly, seniors, how it is very complex and how it's very different now, because like what she said, a lot of them have comorbidities with other issues. So are you able to share with us maybe from what's this? From cradle to grave. Yeah. From cradle to grave. How is it like working with the different populations?
Okay, I must say I predominantly still work with adults.
Yes.
And for a while I was working with the older adults. And when I was doing my master's in the UK, I was working in the forensic facility. So for older adults, I think whether or not it's children, adults, or older adults, we look at of course, we also look at the in terms of the person's trajectory in life. Where is this person at? So if you are looking at a child with neurodevelopmental problems as well as mental health problems, well, a lot of times we don't actually, the psychiatrists don't diagnose children with mental health conditions until a later stage. And I think that's where, because we know that personality only fully develop from adolescence onwards. And also a lot of times there may be other factors that come into play when a child experiences symptoms or talk about symptoms that may allude to certain mental health conditions. For youth, I think looking after their mental health is very important, and actually there are services that cater to school-going children as well as adolescents. There's a REACH service that actually work directly with schools to actually work with the students, counselors, as well as the school management on mental health of the students. So cases whereby the school highlights to the REACH team, the REACH team will assess and then look into the possibility of referral to the child and adolescents mental health service. For maybe older youth who are in the national service, who are transiting to adulthood, and just now you mentioned about adjustment disorder. Adjustment disorder can happen when a person experiences a new event, transit into a new life stage, and some of the clients, occupational therapists also see them in terms of working out the coping strategies to cope with the stressor. And then you are looking at adults, adults at a wide age span, and depending on the type of mental health conditions, we then carry out the evidence-based interventions with them. For the older adults, they do have already certain routines, probably roles, and also probably to a certain extent sometimes even cultural rituals that we need to respect. And therefore, again, occupational therapists, we need to be very, very mindful of that. And we do work very closely with family members when it comes to working with older adults. And of course, older adults, they also may have other medical conditions that we need to be aware of. So therefore, having some grounding in the physical rehab is useful. For older adults, we do come across and treat persons with mild cognitive impairment, with dementia, but do not forget that a person with dementia may also have depression, and we also can see clients who have other conditions such as anxiety-related ones, OCD, sometimes even psychotic disorders in the older adults. So therefore, working with them and the family members to help to support the client is very important. So I think I once worked with a client with dementia, and I worked with the husband to talk about ways to actually
help her adjust at home.
Yeah, support her at home, from daily living to the medication. But then I realized that actually the husband also seemed to have some cognitive decline. So then again, I had to work out with the team about what are the next steps to help the husband. I think as far as we want to, we actually want to enable the couple to live as long within the community as possible.
Wow.
It sounds like there's also a lot of challenges that comes with working with this population group. for mental health conditions. How do you keep yourself motivated, you know, and still stay grounded and continuing in this profession amidst many challenges? And I believe some cases can also be quite heartbreaking. So while you're taking care of someone else's mental health, how do you actually, you know, manage your mental health for that? Yeah.
The motivation comes from, I think, the passion for the profession, and if there is a lot of interest in advancing the occupational therapy profession in this area, I think that drives me. And I think when we talk about resilience, right, it's always about seeing a very positive angle in mind, and working towards it, and being able to overcome challenges, regardless of how big or how small they are. And at the same time, actually, resilience can also consist of other important factors, such as your own coping, how you pace yourself, your self-confidence, etc. So it doesn't take just one day to build resilience. It does take challenges to build resilience. But I think at the end of the day, you might want to think about what is your personal passion, what makes you have this fire in your belly, and what makes you think that you will be able to see the light at the end of the tunnel. And that's very important. So sometimes we do think that, oh, we might not be able to do it, we can't do it. How can we as one person make changes to a client's life? But I realized that I really value teamwork. So with a whole group of colleagues working together, actually it's possible. And we've seen several clients who have actually made very positive strides towards recovery. But of course, at the same time, there are also clients that we do have we do feel that we do feel for. So, for example, there are clients who are very motivated in their own recovery, but the family is very neglectful. So it's and they refuse to engage. So it can be heartbreaking. Conversely, we have got very supportive family members, but they are actually trying their best to help a client, their own family member, their loved ones, who may be sometimes emotionally abusive towards them. So that can be also upsetting to the family, and also that upsets the mental health team also. So what we want to do is to be able to see what we can do as a mental health professional, as an occupational therapist, and do the best we can, and knowing where our limitations are, and knowing which aspects is the client not ready yet, or which aspect are the stars not aligned yet, and being able to wait for it. Yeah, so I think that's helpful. The other aspect of being able to maintain mental health is to pace yourself. So while I did mention that when I was younger, I took on a lot of cases where I was hungry to learn new skills. But at the same time, I think after a while, you need to pace yourself, and you need to be able to take ownership of your own health. So when you know that you are tired, you need to give yourself a break. When you know that you are recharged, you then give it all you can.
Oh, sounds very fulfilling. Like, despite the challenges, you gain a lot of meaning from what you do, and I think that inspires both of us here. I guess for many students who are similarly inspired by hearing you talk about your journey, what advice would you give to students who are interested in pursuing like becoming an OT in mental health? Because like you said, in 4 years we have to be generalists, right?
Yeah.
But after we graduate, like what should we do? What should students do or look out for? Yeah.
So after the occupational therapy student graduates, like what Sarah is at, because you will have lots of options, and you can decide to go into to a mental health position, or you can try out other areas too. And why mental health? I would say that within mental health, there are actually different areas that you can specialize in. So some OTs might think that mental health is a very narrow area. However, once you go into the area of mental health, you can work with children, young people. You can work in inpatient wards. You can work in the outpatient rehab facilities. You can work with clients with mood disorders in the mood disorders ward. You can work with clients in vocational rehab. You can work in step-down facilities. You can work in forensic mental health setting. So there are several areas that you can work in, and you pick up different skills along the way. And I think one thing about mental health is there's no one single right answer. You need to have very good grounding in your mental health theory, and also the different psychiatric conditions, which is why attending my application of psychopathology in occupational therapy is very important. And you also need to be able to articulate what you do, because people may not exactly know what goes behind the occupational therapist treatment plan when they just simply see an activity being carried out. So you need to be able to articulate that. So although there's no single right answer, you need to be able to clinically reason. So that's why with students, I will always ask you all, what makes you decide on this answer? And we need to consider various aspects, the cognitive, emotional, physical, sensory, motor, spiritual, and of course the social environment, the family, even the physical environment. So you need to be able to think broad, and you need to be able to think very deep, because in terms of activity analysis, in terms of the person. So it makes it very interesting. You can never be bored when you work in mental health, because no two clients with the same diagnosis is alike. And it can be quite fun when you carry out activities with clients. So do enjoy yourselves when you work with clients also. I think it's the enjoyment that will also keep the spark alive. And many OTs who work in mental health, they have worked there for many years, because there's always something new that you can learn, and they are unlike anatomy, where you know that certain structures, once they are in place, they are in place. The muscles couldn't be somewhere else. But in mental health, new knowledge is always evolving, and you will always have to keep yourself updated, which is why being research informed is very important. And therefore, working in mental health, there are so many possibilities, so many different things that you can do. And some OTs, they feel that I'm very good in certain activities, I want to use them with my clients. So that's where they get to use their skills too.
Wow. So, for example, I remember watching CNA, and then they're having the whole inside maximum security.
Yes.
Yeah. And so like it got me very interested in the whole forensic thing, and I was very reminded of how you brought in Priya to share with us in the work and productivity module about the forensic psychiatry and the occupational therapists, what we do in that setting. And that got me thinking, like, as very young people who are entering people entering the profession, and then eventually working with people older than us, right? Even though you say there is no one correct answer, I guess we will feel that, what if I say the wrong thing to our clients? What if I trigger them? What if I, so how do we placate these worries? What's your thoughts on that?
This worry is very prevalent. A lot of students are very worried that they will say the wrong thing during placements. But so far, I've not seen any huge disaster as a result of students saying the wrong thing. I think sometimes the more self-conscious we are, the more barriers we put up with the patient. So firstly, I think when you communicate with patients, you learn in school that there are different therapeutic modes, and you probably need to just be aware of yourself as a professional. And once you see yourself as a professional, you embody yourself as a professional, you will want to be able to communicate effectively. And it's very, as I mentioned just now, we seldom say the wrong thing unless you are disrespectful or you nobody has done that, or you know that this particular issue will upset the client. And we do know that there are times where we need to work out certain issues with the clients, and that's where the skills of an experienced occupational therapist come into play. When do we get the client? When do we challenge the client? I like the dialectical behavior therapist principle in the sense that we validate clients, but at the same time we also nudge them towards change. So that's where it becomes a skill. However, for students, for young occupational therapists, what you will be starting to do is to learn how to engage with clients, to be able to carry out activities in a therapeutic manner, use your therapeutic modes, and then observe the client to see whether they respond to change. So if you are observant, if you are able to build rapport with the client, naturally you will be able to communicate effectively with the client. And conversely, if you are too worried, you might start to overthink, and that's where you make communication more stilted. And generally, once you have established rapport with the client, if you start pushing them for change, they may not like it, but they may understand your good intentions. So that's where they will, sometimes clients, they might start by saying that I don't want to do what you say to me. Why is it that you're getting me to do that? But the next day or the next week, they might come back to you and say that actually I had a thought about it, I want to work on this. So doesn't mean that one negative encounter means that it's entirely your fault. You need to look at a myriad of factors.
That's very true, and I think for all of us listening, it's also like a good self-reminder that we shouldn't live in our head and think too much. Not saying we shouldn't think too much, or we should think, but don't overthink and like keep all these worries in our head, because ultimately we have been trained, we have been taught by very good faculty, so we should know what to do lah. Ultimately, and if we don't, we need to learn how to seek help also from our CEs or the people supervising us. Just now you mentioned like a client might say one day, I don't want to do whatever you do, then the next day say he wants to change. I think this kind of relates to another question I want to ask, which is sometimes we hear clients can be difficult, or like, wow, very hard, this kind I don't want to go see. Okay, this is hearsay, okay, not saying anyone has said this, but what's your thoughts on that, like when we say that the client is resistant to therapy?
I think by saying resistant to therapy, we sort of put the fault on the client. But rather than to just use this term very loosely, we need to put on our clinical lens and use a frame of reference. So if we use the trans-theoretical model of change, yes, good student, remember that, then we'll be thinking about at what stage of change the client is at. And if you are putting on the psychodynamic lens, we'll be looking at actually what defense mechanism is exhibiting here, or are there any transference, counter-transference issue? if we adopt the psychosocial rehabilitation approach, we'll be asking ourselves what are the push and the pull factors for the client. So always think clinically, what are the reasons behind clients being so-called difficult, and then depending on the frame of reference that you adopt, use the strategies accordingly to work with the client. So sometimes if we push the clients too early before they are ready, they might resist and could be counterproductive at times. But just now I mentioned about sometimes waiting. Waiting is can be tough, but while we wait, we get the client also over time grow or learn or have new insights into his or her condition, and be able to then engage with you better. So you need to look at what are the other areas in the client's life that might contribute to this.
So from hearing what Prof shared, that is very insightful. I think a few qualities that we can kind of distill with if you are considering mental health, and what are some characteristics that you may probably have to possess in order to enjoy this very dynamic work, would probably be the very openness to learn and to grow with clients, a very genuine interest and curiosity, where I guess you see diversity and differences more as very unique quirks of a person, rather than, "Ayo, this person is making me so difficult." Yeah, so I guess there needs to be a certain spontaneity. If you're a very spontaneous person, that you like a lot of changes, you know, you don't want to get bored, then maybe this field is something, you know, because it's really, there's never really the right answer per se, as compared to more fixed physical conditions, like in the structured hospitals. Yeah, and I think another thing that Prof mentioned that was really insightful and good, I think it's also the very strong like analytical thinking and being able to change modes. Yeah, and know your theory well lah. So Prof, in moving on to
actually, looks like you are very interested in mental health. That's the qualities of a mental health occupational therapist.
Thank you, Prof. I would say that was one of the things that drew me into the field for occupational therapy, after learning that forensics is actually something that, you know, OTs can actually work in. Yeah. Yes, I will consider it sometime in my career, but I guess in considering, as we see how in Singapore the mental health landscape is changing so much from previously having a lot of stigma where people are like, "Aya, you depressed only, you just sad only, it's okay, just be happy,
just cheer up,
be happy, you know, Singapore's
don't
so
think
good."
so much lah.
Yeah, don't think so much, Singapore's so good, what's there to complain about? Yeah, but then after, I think especially after COVID and a lot of awareness and very good work that has been done by HPB and certain national initiatives, like we see them in the posters, in the MRT, on the bus stops,
the advertisements as well.
Yeah, of Prof, I think I need your help with some of the campaign names that we've wrote out. Is it the Live Well?
No, I think that's healthy aging.
Beyond the label.
Beyond the label, yes.
And then we have the mental health one that we kind of see on the SBS Transit. So, Prof, in looking at the projecting towards the future, how do you see the role of occupational therapy evolving in the mental health scene in Singapore?
With the National Mental Health and Wellbeing Strategy, there's actually a lot of scope for occupational therapists to go into. Actually, for many years, there have been unfilled positions for occupational therapists in the community settings. Because when I visit community agencies, yes, the agencies will tell me that I have this position of occupational therapist, I couldn't fill it. Over time, I have to employ another professional. So that I think that's where you don't see a lot of occupational therapists within the community, but there are actually a lot of jobs, and also there's a lot of scope and potential for growth within the community. Now that with the National Mental Health and Wellbeing Strategy, within the community, besides the CRESS team, there are now a lot of commit teams whereby allied health professionals working in the community can drive care, and also a lot of outreach teams the community mental health teams around, where occupational therapists can play a role in. So I would like to see more occupational therapists within the country, so that we can actually really make a difference in clients' lives. Of course, there are other areas that hopefully in the future we can go into, for example, outpatient services for offenders who are discharged from prisons, addiction services, and also probably youth with both neurodevelopmental as well as mental health problems who are transiting to adulthood. So all these areas are really areas that I do hope that in the future there's a scope for occupational therapies. Actually, there is actually scope for occupational therapies. I hope that we will be able to contribute to this area.
That's true.
Okay, so for all who are watching, you heard that we need you.
Yeah.
Yes,
More
we need
to come into like
occupational therapists.
Wow, this is a lot. I think I hope it's okay for me to bring this up. Last week when we were having a meeting for this podcast episode, I actually commented to Prof like, "Wow, Prof, you were a very young OTHOD last time with IMH." Yeah, and then she was like, "Yeah," and then I think one thing I wanted to ask her was, like, as a very young HOD, I read about what you did in Mental Health of a Nation. There's a book you can read up about what OTs do, and I was like, wow, y'all did a lot, leh. Yeah. So, what gave you that idea, or what energy like made you like start off all these things that you did? And then like, do you think younger OTs like us, okay, like her and OT Sir and me, should also embody that same spirit, like still be forthcoming with our ideas and then try to see whether things can work out? Yeah.
That's a good question. So in retrospect, as a young HOD, I of course had the energy, and I had a longer runway to do a lot of new things. And over time, I of course also pick up new skills and learn along the way. There are actually services that we started, and they worked well. There are also new ventures that we went into that, although after a while things fizzle out, but actually it led to very positive benefits. So looking at the journey, what should young OTs embody? I think yes, you can be forthcoming with ideas, but put that into action, because sometimes all talk and no action doesn't amount to anything. So and also when we do have ideas, again back to the grounding on your clinical reasoning. Why is it that's important to do so? Where is the evidence behind it? What's the theoretical basis behind it? So you might need to really be able to articulate that when you put up proposals for funding. So I back in those days at that time, although the mental health awareness was not so high, but it was actually not that difficult for people to understand why certain services were needed. So when I put up proposal and articulate the reason behind it, there was some alignment. People they actually do understand. But of course, there are also other factors that were probably barriers, and stigma is one aspect. So I think there was still mental health stigma. I think we could never get rid of that, but we can always make an improvement by spreading the word, by building more awareness.
Yeah, that's true.
Yeah, so I guess in a way to wow, there are just so many insights, so many valuable nuggets that we have learned from you, Prof. So I guess to kind of wrap up this episode of this podcast, is there any remainder quote or inspirational word of advice or encouragement that you want to give to our viewers about this mental health space and what OTs can do? Maybe like a few phrases.
Perhaps for students who are considering occupational therapy as a profession, we think about what really drives yourself. Do you see yourself being able to look at clients in a very holistic way? And do you see yourself having the energy and the passion to use different therapeutic modalities to help to improve the lives of your clients? So that's one aspect, because the occupational therapy program is actually very rigorous. So don't take it as a walk in the park. So you need to really have the drive and the interest to be a healthcare professional in order to succeed in the occupational therapy program. So as for mental health, occupational therapy, if you do enjoy the dynamic working environment of seeing clients with different mental health conditions, having the drive to create activities, create programs, create services, then that's very, very, very fit for you. Because I think in mental health, sometimes structures may not be in place. So you need to create something out of nothing. And if you are the creative sort, I think that will be very interesting for you too. Of course, another word of advice is always pace yourself, but be open-minded and learn along the way.
Wise words again. I guess on this note also, to just push this question further, there will be some OT students, or if you come in the program, then you realize like, it's indeed not a walk in the park and I'm struggling with my studies. What would you say to OT students who themselves are facing mental health issues?
Oh, okay. All right. So you have studied in the program and in the module about mental health conditions, the psychiatric conditions. Sometimes we do feel stressed, we do feel anxious, we do feel moody. So we may feel that, oh, now I'm especially stressed. This could be different from having a psychiatric condition. So therefore, when we do feel ourselves getting already very stressed or having anxiety about assignment and assessment, find out where you can get help. At SIT, there is a counseling service. So talking to people do help. Some other students, they use other coping strategies such as engaging the leisure activities that they like, or exercise, journaling, just being kind to themselves. Mindfulness may help. I'm certified in mindfulness-based cognitive therapy, so I've seen how mindfulness does help people to be able to self-pace to a certain extent, be present at the moment, and sometimes being present is very helpful. And mindfulness also is underpinning the principle of being present, being able to let go, but always savor the positive aspects of each moment. So all these, I think, can be helpful coping strategies. Of course, if a student has a psychiatric diagnosis, then getting help from a mental health professional is really important. And you do want to still participate in the intervention as you study. So that is important in order to help you manage your studies.
Definitely. I think one thing I like to tell my friends is self-care before healthcare, since we will become healthcare providers. So I think on that note, it's very important that we take care of ourselves before we take care of others. Otherwise, like even in the professional AHPC, right, the professional code of conduct, it tells us like we need to ensure that we ourselves are okay in order to be professionally treating others.
Yes.
Yeah.
That's right.
I guess I would say to add as a survivor of this course. I guess to OT students who are currently struggling or finding it very difficult to persevere in the course, I would say that you are not alone. There are many times us and people before us who have also struggled, and if you will ask your clinical educators and professors, some of them will share with you, there was actually a point in time where I decided, why am I doing this? I want to quit. But those moments do not define you, and I guess it's where we allow ourselves, like what Prof Bhing Leet mentioned, to be present. And I think for me personally, when I was struggling, like being able to share that struggle with my friends, and these are the same friends whom we have also shared like our aspirations and dreams together, to kind of remind us about the reason of what is the hope, and you know, why were we passionate about this cause in the first place. Yeah, and I think a simple quote is that it takes time to grow, and you will grow. Yeah, that science says that all living things grow, so you will grow because you are
and
alive.
grow also.
Yeah, and will grow. So I think be kind to yourself, and allow yourself to have patience. Yeah, to actually go through the process and really trust the process lah. You're not the first person to struggle, and you won't be the last, but there are people alongside with you running this marathon together.
But I must also highlight that the occupational therapy program is not just about stress.
Yes.
It's not just totally stressful. It's actually the people in the occupational therapy profession, we are very fun-loving people.
Yes, you're very fun.
And the whole group is actually very nice to teach. And I think there's a lot of camaraderie within the student body, and also, of course, within the faculty. So I think that's where I find that it's so easy to make friends with occupational therapists, and that's the strong bonding that keeps keep us interested and motivated in the profession.
Yeah, and I think that the part that we actually get to do a lot of things that you enjoy, that not just the client enjoy, but maybe you also enjoy gardening, singing karaoke, you know, or doing all this origami arts and crafts.
Tai chi together.
Yeah, bring your person of what you like, and what you connect or gifted in sports, and these are very valuable traits and aspects of you yourself. Having a life allows you to also bring life to the patients and the people that you are making a difference to. Yeah.
Wow, this is a very wholesome tea that I'm getting. And with that, that's the end of our episode on mental health. Yeah. So thanks for tuning in, whether you're listening in or watching the video. We hope you enjoyed this episode of OT Time on Mental Health. If you enjoyed this series of podcasts, please send us a heart. And then also share this podcast with your friends and family who can listen, and then either join us in the profession, or like just learn more about our profession as well as what occupational therapists do. So if you do want more tea in the occupational therapy, tea, and you know, like tea from hearing from different faculty or OTs. Okay, enough tea puns. Then let us know who you want to hear from, and then we'll see what SAOTSC can do. And since this is just the second episode of this series, I want to take this chance to also thank the people who make this podcast possible, from our profs, SAOT, SAOTSC, as well as SIT alumni, Afida from SIT Library, for teaching us how to use all the equipment that help make this podcast possible. And so with that, we're signing off from with a sip of our tea. Let's say our tea. And see you next time.
Thank you. Thanks for watching.
Karmen mentioned about tuning in to more episodes. We will be having our third and final episode on very interesting topic, but maybe taboo to some, palliative care. So please stay tuned and catch us again. We hope to see you next time.